All right. Well, welcome, welcome. We're very excited to have so many of you joining us from all around the world, both live as well as virtually, watching the recording of this later on. It's our pleasure to let us know, or excuse me, to welcome you all to this Saliva Direct Inc.'s 4th annual conference. First off, we're going to go ahead and have a few words from our executive director, Yasmin Ali.
All right. Thank you, Brittany, and good afternoon, good morning to everybody who is joining us. It is 3:30 here, but since we have such an international group this year, which we're so excited about, good morning, good afternoon, good evening, depending on where you're calling in from. We're excited to have you guys all here. Just wanted to do a couple minutes of a welcome and really to share our appreciation for everybody taking the time to join us today. No matter where you're coming from in the world, we're excited to have you here. Saliva Direct, as many of you know, started as a spin-out of Yale University, focused on saliva diagnostics during the SARS-CoV-2 pandemic in 2020. And since then, we have grown exponentially. Our network has grown, our mission has grown, and where we focus our energy and our time and our connections have also grown. Over the last couple of years, it's been about 3 years since our spin-out of Yale University. And since then, we've done a lot of work to enhance what we're offering our network and also to really build strong relationships and communications around the world. So this being our 4th annual conference, we are so delighted to be able to host it virtually for the first time ever, meaning a lot of our partners from around the world can not only join, but also can present. We have always had a really, really strong relationship with different universities, different academics, and industry folks from around the globe. And this is the first time that we're able to actually convene everybody. And so whether you're on live today or if you're going to be reviewing it later, we appreciate the time that you're taking out of your day to share a little bit of time with us to understand and kind of hear a little bit more about Saliva and what it's capable of doing. So as I mentioned, Saliva Direct is a nonprofit. It's dedicated to enhancing public health through accessible testing strategies and developing and deploying innovative solutions to respond to the world's needs and the health challenges around the world. We provide equitable testing, and we aim to advocate, promote, and advance diagnostic solutions. And one of the ways that we do that is by making sure that knowledge is shared, not just with our network, but with different networks around the country and around the world as well. And so if there are anybody who you would love to have, get a copy of this or to join us, please feel free to share the information as widely as you can. As I mentioned, it's been nearly 3 years since we spun out of Yale University, and we've had a lot of things going on since that time. We still do enjoy pretty close relationships with some of the team over at Yale, whether it be for our mobile testing program or our program right now that we're doing capacity building in Malawi. We've also been running clinical trials for our multiplex in partnership with Yale New Haven Hospital. But since then, we've spun out and we've done a lot of our own things. And so as we go through the next couple of minutes, you'll hear from our director of science, who will talk about our clinical trial. You will also hear about some of the capacity building that we're doing and some of our current research and development work. The cornerstone of Saliva Direct really is around partnership and collaboration. And so as we go through over the next couple of days, as we go through and discuss what's happening on our end, and we hear from everybody on the panels and in the different sessions about what they're doing and what they're working on, keep the idea of being as collaborative as possible in mind. We'd love to hear from you. We'd love to connect you with other speakers if you hear something that's really interesting. If you have any questions, we'd love to hear them. I think our speakers are really excited to talk to everybody about what they're doing, but also to hear what you're doing as well. With that in mind, we do have our annual meeting, which happens at the end of the conference. This is our first time hosting it virtually. And so we are trying to collect as many questions ahead of time as possible. So as you go through the sessions, as you hear new information, if you want to ask a question, feel free to do it in the moment. But if you have anything specific that you think that we as a team should discuss, or we as a group or a network should discuss, please feel free to jot those down or during the annual meeting to really, voice your opinions or voice your kind of questions and your thoughts that way as well. We do take what's discussed at the annual meeting very, very seriously. Our very first annual meeting, one of the things that they said to us is, you guys should spin out of Yale. And the next year we did it. The year after that, they're like, you guys should work on a multiplex. The next year we started it. And so we really do take whatever is discussed here very seriously. And we're trying to be a resource for our community. And the best way to do that is by listening to the people in this room. So as we go through, please feel free to send any questions. We have an amazing team here who is working. Big shout out to Brittany and Victoria for being the masterminds of this annual conference, especially this virtual conference. And we have team members here. We have Judy, we have Laura, myself. We will be taking notes and we will be open to answering any questions that you might have. And we're looking forward to it. So those are just my quick words. If you have any questions as we go through, please feel free to message me directly or message the group. We're going to kick it over to Alex, who is our director of science, and she's going to have a couple of words and she's going to share some slides, and then we'll go from there. Again, I want to thank everybody for taking the time to join us, and we are so excited to have you here.
So with that, it's my pleasure to welcome you to the live portion of the event, where we're going to hear from three wonderful speakers that are going to be sharing about the opportunity for salivary diagnostics. First up is going to be Dr. David Vigerust, and he is going to be sharing with us about saliva diagnostics, the future of prevention in dentistry and medicine. Dr. Vigerust, over to you.
So thank you very much, and welcome to everybody, and a very sincere thank you to the organizers for allowing me the opportunity to present here and to share some of the work that we've been doing over the last several years. Just for the sake of disclosures, just going to let everybody know that I'm faculty at a number of different universities, and I am, excuse me, the Chief Scientific Officer for Spectrum Solutions, which is a clinical diagnostic and development company that has spent the last several years specializing in salivary diagnostics. So just to give you a brief overview of the lecture and the goals. So I'm going to spend a few minutes today, even though we only have 20 minutes with each other, to discuss, some of the benefits of saliva as a biosample for both disease prevention and management. Now, I've been in this particular space for the last 12 years. So this is my 12th year using saliva as a biosample. We're going to talk a little bit about some of the utility and benefits, and then I'm going to provide 7 examples of the utility and the benefits of saliva diagnostics in both clinical dentistry and medicine. So I want to reach back to about 100 years ago when the famed physician Charles Mayo, one of the founders of the Mayo Clinic, had said that the future of medicine lays in the hands of the dentist. And he further said that the next move in preventative medicine is likely to come from the dental profession. So as most of us realize, the diagnostic capability in medicine drives the majority of the decision making. That doesn't happen in dentistry. So there's been a disconnect in dentistry, and there's been a disconnect in the way that we can have a medical dental collaboration that will allow for more preventative medicine and more remote diagnostic capability. The real power of saliva is that it's non-invasive and it can be used in a variety of fashions that allow us to remote monitor patients. You can send a kit to the patient's home. They can provide the sample, send it back into the lab. The physician can then, go about the analysis of those results and then provide some guidance. All of us that are part of this meeting are fans and enthusiasts of saliva as a sample media. And most of us are aware of all of the different capabilities that saliva offers. It has a multifunctional purpose. It has very much of a mirror of blood. It's easy to collect, and it allows us to look at a vast portion, about a liter to a liter and a half saliva. So it's a cold sample solution that allows us to do a broad range of genomics. And for cancer screening, we would just take neat saliva in an Eppendorf tube, a 15 mil conical tube, and send that into the laboratory. That oftentimes resulted in contaminated sample, resulted in patients who had just had a meal or had just recently smoked. So you ended up getting a sample that was not the ideal sample that you needed to actually conduct a productive analysis. So now we have a myriad of solutions out in the market now that allow us to collect, preserve, and transport saliva. I think that one of the linchpins to allowing saliva to be will elaborate further. It allows us to look at infection status. So one of the areas of interest of mine has been periodontal infection, respiratory of sexually transmitted organisms, HPV, gonorrhea, a whole host of them can be very effective. Invasive collection type. There are a number of companies across the country and across the world that use this to monitor hormonal status. This is one investigation and analysis of nutritional and metabolic influences. Now, most of us know that back in the concept of so this largely work of David Wong, but within omics, the last 10 have encountered saliva is in the area of genomics, ancestry testing, testing for certain types of genetic disorders. Looking at nucleic acids for infection status. I'll share some data that we've acquired over a variety of different collaborations. Currently we have 5 IRB studies going on, and all of them are looking at saliva as the principal sample media. Collection, the nice thing about this is it's reliable, it's reproducible, and allows us to get a very nice biosignature response from the patient. So what I'm presenting to you here is what happens quite often, at least in our experience, is that when we present the idea of saliva as a sample media, from physicians, we get a lot of comparison to blood, blood being the gold standard. So this was from a study that was out of Stanford a number of years ago from the 1000 Immunomes Project. And we were interested in trying to look at a concordance and correlation in a sample proteomic buffer between a number of cytokine and immune markers. And we're looking at a comparison between saliva and blood, basically serology, from the same patients. We took 61 patients, collected blood, collected saliva, collected stool, and we basically collected every kind of biosample that we could from these patients. And what we're able to show is that although it's not perfect, we are able to show a very good comparison and concordance between saliva and blood. And in this particular instance, we're looking at a Luminex platform. But we've gone on to look at not only cytokines, we've looked at proteins, we've looked at hormones, we've looked at a broad range of analytes. And here, to kind of further illustrate what I was mentioning before about one of the principal issues early on was the stability and the recovery of our sample or our analyte of interest from that saliva sample. So this is a project that we did in collaboration with Penn State. And this is a pediatric neurologist who was very interested and continues to be interested in the idea of monitoring concussion in youngsters via saliva. So what happens if they're playing football or playing hockey and they were to suffer a concussion, we could take an immediate saliva sample from that patient or that participant and then look to see whether or not there are any early markers of concussion or early markers of inflammation that are present. And what we see here is over a time course of 100 hours, we are able to monitor at least 3 of these important cytokines, MIG, CXCL9, and interferon gamma, over the course of that time course. And we're able to continue to pick up these markers in the saliva samples. And then we did some comparisons between a variety of different collection devices to try to illustrate and show whether or not you need some kind of stabilizing proteomic buffer, whether or not neat saliva works as well. So we've done a fair bit of work with a proteomic buffer that a number of companies have utilized, just to kind of preserve that sample so that when it arrives in the lab, we still have a viable case for being able to analyze the samples. Back during COVID, one of the interesting questions was whether or not patients were achieving a protective antibody response after getting the COVID vaccine. So we went about looking at both IgA and IgG, and just looking again in the stabilization solution, we're looking to see whether or not saliva is an appropriate media to be able to detect reliably and consistently IgG and IgA. And here we're looking at a very short time span. We're only looking over a couple of days. It's at room temperature. So again, we don't need to keep things on ice. Doesn't need to be protected in the temperature sensitivity perspective. And what we can see is that we are able to quite oftentimes stabilize the solution, stabilize the sample, and then with a high degree of consistency, we can continue to detect relative IgA and IgG concentrations in those samples. So, over the course of the last couple of years, and largely in not response, but largely credited to COVID, if there's anything we can credit to COVID, was significant advancement in the technology around the preservation of saliva. And that's allowed a lot of labs to be able to very efficiently continue to test saliva as a sample media. So one of the things that, again, as part of that original Stanford study that I was part of back prior to COVID, is we're interested in looking at the proteomic applications of saliva. And across a number of different conditions, from oral cancer to celiac disease to concussion and TBI and inflammation and aging, at that particular time, Stanford and the 1,000 Immunomes Project was looking to see if we could build a panel from blood and from saliva that would offer an indication of someone's immune age. So basically, does that person of a given chronological age have an immune system that reflects the chronological age, or do they have an immune system that may be reflective of somebody younger or somebody older? And we looked at a broad range of proteins. In this case, this is a SomaLogic platform. SomaLogic looked at that time, 7,500 proteins. We did a comparison between serum and saliva across 61 participants, and we showed that there was a high degree of correlation between the two sample types. But we also showed that we were able to detect within that 7,500 proteomic marker set, we were able to detect a number of very important biomarkers for each one of these diseases. From oral cancer, we're able to look at a number of cytokine biomarkers, celiac disease, a variety of immunoglobulins, IgA and IgG, concussion, important proteins that are secreted in the brain after concussion, that are some of the first proteins that get into the saliva. They reach the saliva before they get into the blood. So we can actually detect some of those markers in saliva ahead of when they would be detectable in blood. And then we were able to look at a broad range of inflammatory markers that are reflective of aging. This is just a further reflection because we wanted to demonstrate that the analysis on the SomaLogic platform was not a one-time event. So in order to do that, we decided to look at 5 different platforms: Luminex, Olink, SomaLogic, ELISA. We've looked at microarrays. We've looked at a variety of different assay types. And again, looking at the same type of inflammatory biomarkers, we're able to reproducibly and reliably detect in saliva all of these markers across a variety of different platforms. So that means that saliva is compatible and can be utilized in ELISAs, in SomaLogic, in Olink, in protein arrays, in RT-PCR. So there's really no limit to the platform that can be used. And in fact, I recently spoke to someone who is using infrared spectroscopy and saliva to detect lung cancer. So the capabilities are opening up, and they've opened up in large part because there is a worldwide interest in saliva as a sample type. And there are a lot of laboratories and investigators who are looking at their particular platform of interest and saliva as a viable sample type. This again is just to further illustrate in that 61 patient cohort that we can reliably detect markers of ulcerative colitis and inflammatory bowel disease in the saliva. So that allows us to go back to what I was saying before. That allows us in these kinds of patients to do remote patient monitoring of them. Doesn't require them to come into the office to get blood drawn or to get a sample. It allows us to be able to do this very efficiently from a distance. And that's something that I think many patients are really looking for, is that ease and that convenience of being able to follow their particular disease without having to come into the office and get a blood draw or get an invasive procedure. This just further illustrates that we can do multi-omic capabilities with the saliva. This is out of the same samples. We're looking at a variety of cytokine markers. And at the same time, we're looking at pathogen DNA profiles in that same saliva sample. And that's trying to make the connection between the periodontal pathogens that result in periodontal disease, mucositis, and implantitis, and the inflammatory markers that further degrade that whole process of disease and drive the pathogenesis. So from the standpoint of prevention on both the dental and the medical side, we can see from, I'm just taking an example of oral pathogens. Oral pathogens have a systemic impact across every single organ system that we test now routinely for with blood. And quickly, I'm going to try to run through the 7 examples. So I think we can all agree that there's been a wealth of literature in the last few years that have described this medical dental connection, the connection between what happens in the oral cavity and what happens in the rest of the body. And there are connections between periodontal pathogens and the development and pathogenesis of atherosclerosis. There is a bidirectional relationship between oral pathogens and diabetes. There is a bidirectional relationship between oral pathogens and neurocognitive disorders. And there's also a very high prevalence of periodontal disease and those pathogens driving inflammation in the genesis of fatty liver disease. So when you look at just from the standpoint of periodontal applications, thinking of the mouth as the portal for all development of disease, we can see that there is a very broad range of organisms within the oral microbiome, the majority of which do not cause disease, the majority of which are healthy commensal bacteria that are helping us process a number of different features, right? They're helping us with digestion, helping us with everything that we need to be able to accurately or effectively process what we consume, what we breathe. On the right-hand side there, I'm just showing an example report showing a potential patient that has very high levels of some of these harmful periodontal pathogens. That likewise occurs, those high-risk pathogens can get into the implant. So when you have a stent put in for a cardiovascular patient, or you have an artificial replacement, a knee or a hip replacement, the periodontal pathogens can oftentimes extravasate from the mouth and get into that implant. And that happens within the oral cavity, it happens extraoral as well. So here's an example of periimplantitis and mucositis that are largely driven by these pathogens that generate an inflammatory process that drives rejection of the implant. This was a study that we did with David Wong at UCLA. And basically what Dr. Wong wanted to do was to see if we could use saliva as a mechanism for determining the treatment efficiency of non-small cell lung cancer. So what happens in NSCLC patients is they are prescribed what are called tyrosine kinase inhibitors. These are drugs that target the EGFR gene. Ordinarily, in order to find out whether or not the patient is still able to benefit from that particular drug, is you require an invasive bronchoscopy. So here we took a saliva sample from the patient. We were able to detect in very high and very reliably, we were able to detect the mutations in EGFR mutation that allowed the physician in a non-invasive remote fashion to alter the patient's drug therapy in response to their small cell lung cancer. That means that this patient didn't have to come in and do an invasive procedure. They just had to offer a saliva sample. It's an example here of those same pathogens contributing to cardiovascular disease. They contribute to metabolic disorders like inflammatory bowel disease, NASH, colorectal cancer. Some of these oral pathogens drive the development of colorectal cancer. As I mentioned before, there's a bidirectional relationship with diabetes. You can use saliva in the diagnosis and the treatment of pregnancy risk. Oftentimes, those same periodontal pathogens result in low fetal birth weight, preeclampsia, premature rupture of the membrane. So by a simple non-invasive salivary collection, we can monitor potential pregnancy risks, cardiovascular risks, diabetic risk, metabolic risks. So what we're coming down to is a new horizon when it comes to salivary diagnostics. And I think more and more laboratories are considering saliva as a viable sample type in relationship to blood. Not everything can be detected in saliva, obviously, but it serves as a very good adjunct to blood, allows us to continue to monitor from a remote environment the patient. They don't have to come into the office as much. They don't have to subject themselves to an invasive procedure. And so every chronic disease across every organ system is initiated, aggravated, or defined by the presence of chronic systemic inflammation. Much of that begins in the mouth, and every single bit of it can be monitored with a saliva collection. Whether that's a point of care device like what you see on the right-hand side here, or a clinical diagnostic that's sent into the laboratory, saliva is becoming a very much preferred and viable sample type across a variety of different types of disease conditions. And the technologies that we've been using for blood are very easily adapted to saliva. And I appreciate your time today and your attention. And if anyone wishes to contact me, here's brief contact information.
Thank you, Dr. Vigerust, for that wonderful presentation. It was a great overview of all the many applications that I think we're going to hear quite a bit about actually during this conference. Really appreciate you kicking it off. I saw that there were a couple of questions that came through the Q&A chat. We'll go ahead and save those for the question and answer session that's going to happen at the end of today's Zoom call. And so up next, we'll kick it over to Dr. Robinson Sabino-Silva. If anyone wants to continue putting in questions, please do use that Q&A feature down at the bottom. Dr. Sabino-Silva is joining us from Brazil, so we're going to go from North America down to South America for this next presentation. And he's going to be sharing about artificial intelligence-powered salivary diagnostics for systemic disease, innovations in on-demand.
Okay, perfect. Thank you for the organizer for having me here. It's a great pleasure to talk in the 4th Annual Salivary Diagnostics Conference. My name is Robinson Sabino-Silva. I am the principal investigator in the Innovation Center in Salivary Diagnostics and Nanobiotechnology at Federal University of Uberlândia. I will talk about the artificial intelligence-powered salivary diagnostics for systemic disease. I have some potential conflicts of interest because we filed 18 patents in the National Institute of Industrial Property in Brazil and 4 in the PCT International. And the aims of this presentation is explain why salivary flow rate, composition, and biomarkers must be routinely assessed in the dental practice, and describe how artificial intelligence is transforming salivary diagnostics in the dental settings. As we know, saliva is an essential biofluid that is very important for oral health, that reflects systemic disease and can express biomarkers for both oral and systemic disease. We also know that we have parasympathetic and sympathetic outflow that control this salivary secretion, and we have in the salivary glands are highly vascularized, enabling transcellular and paracellular transport of a range of the several molecules. In this context, it's very important we know that more than 95% of total protein in saliva are synthesized in salivary glands, and 73% of the salivary proteins are not present in the plasma. Thus, it provides a unique opportunity to discover salivary proteomic biomarkers present only in saliva. In this context, we also know that 99% of water is in saliva is composed by water. And we have more than thousands of peptides, proteins, and messenger RNAs. And we also have hundreds of lipids, metabolites, several types of microorganisms like viruses and bacteria and fungi. And we also can detect legal and illegal drugs, ions, and other organic molecules. In this context, we also know that saliva has multiple functions, including remineralization, buffer capacity, wound healing, antibacterial, antiviral, antifungal, lubrification, digestion. And in this context, the question is how we don't measure salivary flow in the clinical settings. This centennial publication of JDR, Journal of Dental Research, raised this pivotal question recently. Thus, it's very important for us we remember that if your answer is rarely or never, you are not alone, but this must be concern us. Unfortunately, saliva is still seen by many as a something conventional clinical dentistry, but it interferes in the assessment, restoration, cementation, endodontics, and surgery. And it has led most of dental school around the world to give saliva very little attention, especially during the clinical years. But this is a serious oversight. And in the modern dentist, we measure salivary flow because it is not optional. We need to measure the salivary flow for each patient. Besides, we also know that hyposalivation is present in 20% of the population, and this number increased to 33% in older adults. In this context, we also know that we have hyposalivation leads to the lower bicarbonate concentration, reducing in this case the buffering power that shields the oral health and do not prevent for acid erosion. In this context, we also know that the modern dental patients is shaped by the new epidemiological reality that occur in dental settings today. We know that today is very more common the presence of polypharmacy, xerostomic drugs, systemic disease, low water ingestion, anxiety, depression, other neurological disease, gastroesophageal reflux, consumption of dietary acids, bruxism, and no cariocervical lesions. In this context, we know that this hyposalivation is very related with other problems in oral health, including dental caries, non-cervical lesions, periodontitis, candidiasis, halitosis, and edentulism. Thus, the number of the World Health Organization also told us that 3.5 billion people worldwide are affected by oral disease, and 3 out of 4 people affected by the oral disease are living in low and middle income countries. Thus, we need to improve this data. Besides, we also know that when we have a reduced salivary flow, we have a higher caries prevalence. Thus, it's very important we measure the salivary flow. Besides, when we have hyposalivation, it enhances the Candida albicans colonization, and it also correlates with gingival inflammation in elderly population. Besides, we also know that 1/3 of all women are postmenopausal, and this population experience an increase in the presence of the unstimulated salivary flow rate with a reduction in the presence of hyposalivation. Thus, it leading to increased rates of caries, gingivitis, and alveolar bone loss. Besides, it's very important we think that no restorative material is more durable than physiological dentin in our teeth. And beside this, it's very important. We believe that our enamel and our dentin are better than the all restorative materials. As you can see here in this figure, that when we have one patient with a normal salivation, we have a higher presence of the restorative materials in the mouth. But in the cases of hyposalivation, this number decreases. And the question is easy probably for us here, because how we can collect saliva? It's very easy in the dentistry field. We can easy to collect saliva from the patients in the unstimulated salivary secretion during 5 minutes, and we can perform an structured clinical story of cyalometry. It will be provided in English free of charge in our salivanano.com site. And we have several types of collection devices. And in the clinical settings in dentistry, we can just perform some very simple information for the patients, and we can collect saliva during 5 minutes. In some cases, we can use simple plastic cups with a hypodermic syringe, and we also can detect the salivary flow. And in some cases, with standard cyalometry, we can use better graduated tubs and calibrated volume indicators, and also pH indicators. We know that when we have the presence of less than 0.1 milliliters per minute of saliva in unstimulated condition, we will have one hyposalivation cases. And there are some other tests that were proposed by some groups from Netherlands that we can measure spin barkai that can be also connected with the caries presence. And we also probably can detect in each patients the salivary pH measurement. The unique country that we see that can show for us a true example of equity in prevention using measurement of saliva is the Sweden, because in that country they double the dental subsidies for the patients that have hyposalivation. In that case, we have a very priority for these patients. Besides, we also know that salivary diagnostics have some advantages from blood. We have one non-invasive, economic, painless, easy to transport, do not coagulate, and permits a personal collection, although we have some translational and clinical frontiers to improve. Today in the market, we have several salivary tests in the market, and we believe that when integrated with artificial intelligence, we can improve this test. Our group have worked to select bioactive molecules using bioinformatics together or no with artificial intelligence, phase display, functionalization with nanoparticles, and we can work with diagnostics in photonic biosensor, electrochemical biosensor, lateral flow biosensor, and mass spectrometry. And we have worked with several diseases. I don't have time to talk about all tests that we are doing now, but we have worked with metastatic, chronic, neurological, respiratory, infectious, and toxicological disease that can be detected changes in the saliva applied for different platforms. One platform that we developed was one cost-effective and customized solution named SagaPep. This SagaPep can define one protein target, and using bioinformatic data sets, we can modeling our new peptides or using salivary peptides as data sets. And we also perform molecular docking and dynamics. And after that, we can improve these bioinspired molecules using artificial intelligence algorithms algorithms specific for this, and using this platform, we can better connection with our target. In this example, you can see that we publish a paper in the one best journal in the artificial intelligence algorithms, and we detected this our data in red one, and when we applied the SagaPep, we have these green peptides that have higher energy, because when we have a better docking, we have a lower energy here. Thus, our platform was enabled to get better dockings with our target. In a recent paper accepted in JDR, we selected some naturally occurring peptides that have a very big attachment with the SARS-CoV-2, and we synthesized these salivary peptides, and these salivary peptides were able to integrate with the spike-2, and the connection with the spike in the SARS-CoV-2 virus can reduce the integration with the ACE2, and in that case, these salivary peptides reducing the presence of the SARS-CoV-2 in the culture of cells. We believe that we can, in the future, insert these peptides in other products of oral health. We have another study using analysis in norovirus, because we know that it is one important virus that affects around 1 billion people worldwide, and saliva can transmit this virus. In that case, we performed this analysis together with the NIH in the US, and we used the same platform that I told you, named SagaPep, that we provided at our university in Brazil. And we selected the best peptides. In that case, we use it as a diagnostics. Using one gold nanoparticles electrodes, we inserted these salivary peptides in the electrodes, and we performed this analysis using one electrochemical device. As you can see here, we have a very good detection of this virus using saliva samples with a very good accuracy. I have one short video, and the test can be done with a very little presence of saliva. We can just pipe this saliva in the electrode, and we will have in the cell phone, in the smartphone, we will have the presence of the spectra that will be analyzed by the artificial intelligence algorithms. To reduce the test, the price of the test, we are also working to produce these electrodes in our lab in Brazil. It is performed in the laboratory of nanotechnology in Brazil. And we also are working with the magnetic nanoparticles. We believe that if we integrate these magnetic nanoparticles with our bio-inspired molecules, we can insert these magnetic nanoparticles together with our peptides, and in that case, when we put one still here, we can have the presence of our biomarkers in the pellet, and when we discard the sobrenadant, we will have an increased concentration of our biomarker. And we also have worked with sustainable saliva-based diagnostic platforms. Our interest occur because the ATR FTIR is a reagent-free, sustainable, cost-effective, rapid, simple to prepare, and very reproducible technique. And we believe that using reagent-free, we will have a more sustainable world. In that case, it is a publication in the Nature Protocols that show the spectra of biofluid. And as you can see here, in just one spectra, we can see the presence of the vibrational modes present in lipids, proteins, nucleic acids, and carbohydrates. And in that case, we will have a multi-omic analysis using just one platform. This is our test that we performed here. We have one saliva collection, and 1 microliter, we will have the presence of all salivary components that we told us, and we can just insert these salivary components in our portable ATR FTIR. In that case, we will have 1,000 of potential biomarkers in just one test. And considering this difference in the spectra, in the red and black, our artificial intelligence algorithms can discriminate both samples, and these algorithms can be evaluable 24 hours per 7 days per week. And after that, we can easily send to the smartphone of the patients. We have used several different artificial intelligence algorithms, and together with other colleagues at UFO, we also have worked with deep learning in some cases. This is one example that we detected the presence of the Zika virus using this platform in saliva with 100% of accuracy. We also detected the presence of the chikungunya virus in one animal model infection using the same platform. We have more than 20 publications in this field, but this is another example using saliva to detect chronic kidney disease. In that case, it was our first paper in humans. We don't use it artificial intelligence, but we are working in this area now. And this is our other work using more than 200 samples of non-diabetic or type 2 diabetic patients. And we get around 85% of accuracy using one neural network artificial intelligence algorithms. And as you can see here, we have a detection based in multi-omic because we have our detection based on the proteins, carbohydrates, lipids, and nucleic acid that are described in our SHAP analysis. Besides, we also detected the presence of Helicobacter pylori in saliva. We just spiked the Helicobacter pylori in different concentration in saliva, and in that case, we are efficient to get one accuracy around 90%, and this data indicate that we can move to detect several pathogens in this area. We also have one work with the Federal Police of Brazil, and we detected the crack in an animal model. In that case, we can see the difference from these tests, and we detected with a higher efficiency, around 90% to detect this drug in the saliva. We also worked with gold nanoparticles because, as you can see here, we can, when insert gold nanoparticles, we perform a better view of lipids in our analysis. During the COVID-19, we detected, we published a paper about the coronavirus impact in the dentistry and potential salivary diagnosis. After that, we also published some papers to show that in some cases we have the presence of SARS-CoV-2 positive in saliva and negative in nasopharyngeal swab that will be also comproved in our meta-analysis published later. And more recently, the last part of the presentation, we have worked also with lateral flow assays, and we tried to insert our novel peptides here to detect novel disease. And we also have worked with mass spectrometry. In that case, we have detected difference in 27 lipids in the autism spectrum disorders. And when we use AI models, we can detect this condition in 85% of accuracy. Thus, our group imagine a new horizon that a visit to the dentist can diagnose oral and systemic disease. A new horizon that where physician can diagnose several diseases with a drop of saliva. And we believe that salivary diagnosis can reduce the cost of the health procedures. And we work to make this dream a reality with a novel saliva-based sustainable diagnostic platform. I really need take sorry, I forgot the word, but this is our group that performed this analysis, and I need also show our contacts that we can talk if you have any question, and this is our grant support. Thank you so much.
Thank you, Dr. Sabino-Silva. Appreciate you sharing such insights from your work and getting to showcase just how much variety there is, particularly in your lab. Really appreciate you taking the time. For those who are interested in submitting questions for Dr. Sabino-Silva, please use the chat function down in the bottom. There's an option for submitting questions that we'll get to at the Q&A at the end of today's session. All right, now we are going to go from North America to South America, all the way over to Australia, where Dr. Eric Chow is joining us today. He's going to be presenting from Monash University in Australia, specifically on the spit and spread, the role of saliva in the transmission of sexually transmitted infections.
Thank you so much for inviting me to this conference. Yeah, so today I'm going to talk about like how we actually use saliva for STI diagnostic, and also to understand like how saliva can be a medium to transmit sexually transmitted infection. Here, my disclosure. So before I start, I would like to just talk about like where this work was done. So most of our work actually was done at the Melbourne Sexual Health Centre, where I'm actually based at. And this is the only public STI clinic in Melbourne, in Australia, which we serve 6.6 million people in Victoria. And you can also see in the graph below, we're actually seeing like a lot of patients like each year, and with a very high demand. We locate in Melbourne CBD, and there's no referral required, and we only accept walk-in patients. So the traditional STI transmission model have mostly focused on lightly penetrative sex and also the exchange of body fluid. And saliva is always often involved in many sexual activities, but this is always left out when we talk about transmission and risk, because it has been assumed to carry a very low risk in STI and also HIV. But now I think like this assumption has been changed and also being questioned based on like some of recent studies. So I'll probably just start with some evidence about like gonorrhea in saliva. So gonorrhea is one of the most commonly transmitted infection, and we conducted this study with 33 untreated gay men who had oropharyngeal gonorrhea confirmed by culture. And when they return, excuse me, and when they return to the clinic within 14 days for treatment, and we collect the saliva sample, and then we test the saliva by net, and the result actually showed that 100% of this sample test positive by net, and 43% test positive by culture. And we must probably acknowledge that culture sensitivity is actually very poor, but having 43% test positive by culture actually is a very compelling evidence showing saliva can carry infectious gonorrhea infection and also can be transmitted through saliva exchange. So this is a cohort study that of 100 men over 12 weeks with weekly saliva sample collected with more than 1,000 saliva sample. So in this study, we examined the incidence and duration of oropharyngeal gonorrhea and chlamydia using weekly saliva sample. So this study was conducted before COVID, and throat swab were usually collected by clinician and not by patient because patient were found very difficult to collect throat swab. But this definitely has changed dramatically when COVID hit. So we asked participants to mail the saliva sample back to us rather than coming to the clinic weekly. And the table below actually shows that when we collect the throat swab and the saliva sample at the same time point, it actually shows a very high concordance of gonorrhea detection. So, however, saliva is not an approved diagnostic specimen for STI diagnostic in Australia currently, so we can only use it in the research context. So the next study is actually led by my postdoc, Tiffany Phillip. We recruit 42 men with throat chlamydia. So participants were asked to accumulate saliva for 30 seconds by rubbing their cheek and also the teeth through the tongue to generate enough saliva. Some patients actually report they have been find it a bit difficult to generate saliva, and also the lab also sometimes will take different volume of saliva. So and then we actually ask them to spit into the specimen jar and then for testing. So in this study, we find that 69% test positive for chlamydia in the saliva by PCR. And the figure below actually shows that chlamydia bacterioloid in saliva was very similar to the throat swab that we collected. But we were unable to determine the portion of a viable chlamydia organism because culturing chlamydia is actually quite challenging. The next one that I want to touch on is syphilis. This is a study that conducted in China. They recruited about 200 patients across different clinical syphilis stage. The study collected paired saliva sample and plasma sample, and they found that Treponema pallidum DNA was found in significantly higher concentration in saliva than in plasma. And also they found that the higher loads observed in patients when they have secondary syphilis. They also find that saliva, the DNA will actually gradually decrease after antibiotic treatment. So this is a really strong study showing it is very important that it is a very strong study actually showing that saliva collection could be served as a non-invasive and also very convenient method, not just for diagnosis, but also an indicator for therapeutic effectiveness. So while the global mpox outbreak, there has been a lot of research looking into how it is spread and transmitted. And this study from Barcelona conducted during the 2022 mpox outbreak and also provides some supported evidence by showing the role of saliva in STI transmission. So they recruit 12 patients with mpox, including 147 clinical samples from different anatomical sites. And they found that mpox actually was found in 92% in rectal swab, 67% in feces, 75% in urine, 58% in semen, 83% in the nasal oropharyngeal swab. But all patients, that's 100%, actually test positive in the saliva. And this is also another evidence showing that saliva can carry infectious multiple virus, bacteria in relation to sexually transmitted infection. So understanding how STI is transmitted is very fundamental to effective prevention and control. So over the last few years, I spent quite a lot of time working very closely with Professor Keith Valley, who is the former director of the Melbourne Sexual Health Centre. And together we actually have been challenging the traditional model of STI, which has focused on condomless penetrative sex. But we actually propose a new paradigm showing the mouth can play a very central role in STI transmission rather than what we previously thought. So I'm going to use gonorrhea as an example throughout my talk. So kissing is often the first way that people exchange saliva, and it's very commonly occur during sexual activities and also daily life, but it's very rarely considered in STI transmission. So the idea of gonorrhea could be transmitted through kissing is not entirely new. So back in the 1970s, there have been several cases proposed gonorrhea could be transmitted through kissing, but there has no epidemiological study or data like to prove this hypothesis. Sorry. So we designed a study to specifically examine kissing as the transmission route, and we recruit more than 3,000 gay bisexual men at the Melbourne Sexual Centre. So we asked them to report 3 distinct risk exposure in the past 3 months. So they're kissing-only partners they did not have sex with, sex-only partners they only have sex with but no kissing, and also kissing with sex partners, so they someone that they have kissed and have sex with. So this question allowed us to isolate the effects of kissing from other sexual activities, and also other participants were tested for oropharyngeal gonorrhea using NET. We also adjusted for potential confounding like HIV status and age. So the result here shows that people who have kissing only with 4 more partners and also kissing with sex partners are significantly associated with pharyngeal gonorrhea. But when you look at in the middle part, people who have sex-only partners is not significantly associated with throat gonorrhea. So this data actually provide the first epidemiological evidence showing kissing alone can transmit gonorrhea. And there has been more evidence showing this data, also including some data from the US as well. So apart from kissing, saliva can also be exchanged in other ways during sex, like when it is used as a lubricant during sex. And we surveyed about 1,000 gay men in Melbourne, and we find that about 69% use their partner's saliva as a lubricant for anal sex in previous 3 months. So this practice was strongly linked to condoms anal sex. Near 80% of men did not always use condom and use saliva as a lubricant, compared to 60% of those who always use condom. And we found that men who use partner saliva had 2 times higher odds of having anal gonorrhea, even after we adjust for other confounders such as condom use. And so this study actually showed that saliva can also serve as a medium for transmitting gonorrhea and potentially other SDI from the throat to the anus during sexual activities. So now I'm going to share a case study that was done by my former PhD student, Vincent Conley's. So here we have an index patient coming to our clinic. So they are a non-binary person coming to the clinic for STI screening, and they test positive for the throat gonorrhea, but negative for genital gonorrhea. So we ask, and then we ask some of the sexual history, and they report they would test negative for gonorrhea 5 months ago. And they also report they had sex with 4 different men, and all these 4 men actually test negative for gonorrhea subsequently. But we didn't know which anatomical site, whether it's a genital site or whether it's the throat site were tested, but we assume mostly will be the genital site. And then we further ask more questions, and they report they actually kissed a woman at a music festival. And this woman actually test positive in the throat, but negative in the genital area. And then we actually identified this network, kissing network at the music festival. And we actually find that 6 of the 7 participants actually test positive in the throat for gonorrhea, but did not test positive in the genital area. And all these people actually kiss. So this is also another very strong evidence showing kissing can actually transmit infection. So we also look at heterosexuals population. So if someone actually report their partner have gonorrhea, we will screen for genital gonorrhea and also pharyngeal gonorrhea, regardless of their sexual practice and symptoms. And our data actually shows that 18% of men test positive for throat gonorrhea, compared to 46% of women test positive in the throat. And this difference suggests the transmission pattern may vary between men and women, possibly due to different sexual practice or biological factors. This slide shows multi-site gonorrhea infection, which is coming from the same study, but highlight nearly 90% of men test positive only in the throat, compared to 40% of women test positive only in the throat. And this is a very important finding, suggesting that if we only test the genital site and ignoring the oropharyngeal site, many infections will be missed, and meaning that this individual would go undiagnosed and potentially transmit the infection to their partners. So lastly, I just want to touch on some potential intervention that we have been thinking of because we know that the mouth is actually a key transmission anatomical site, and also saliva can carry infectious pathogens. So we were thinking like whether mouthwash could actually interrupt the transmission route. And very interestingly, Listerine was first used as a surgical antiseptic, and the producer actually claimed that it could treat different conditions, including gonorrhea. But these historic claims always were not evidence-based, so they we poem to investigate whether mouthwash can prevent or treat gonorrhea. So we have done a few laboratory studies. So we test different commercial mouthwash products, including Listerine Cool Mint, which contains 30% of alcohol, Listerine Zero, which does not contain alcohol. So you can see in the pink square on the slide, which actually showing that both mouthwash show a very significant inhibitory effect against Neisseria gonorrhea. But when you look at the last column, when we use PBS as a control, show no effect at all. When you look at in the middle, the orange and the red column, we also test 20% and 30% ethanol and then it actually showed no effect at all. So that actually showing that while drinking or gargling whiskey probably would not helping to get rid of your gonorrhea in the mouth. This also led to our first randomized controlled trial of mouthwash for gonorrhea. We recruit 58 untreated gay men with culture-positive throat gonorrhea, and then we randomized them to rinse and gargle either Listerine or saline for 60 seconds. And the result actually showed that gonorrhea positivity was 52% in the Listerine group, which was significantly lower than 84% in the saline group. The data actually suggests a single use of Listerine could potentially reduce the bacterial load of gonorrhea in the throat. This is actually very promising, and then we actually did this large multi-site randomized controlled trial to examine if daily mouthwash can be used to reduce the risk of pharyngeal gonorrhea. So we collect our pharyngeal swab and also saliva sample over 3 months. We recruit more than 400 men in Australia, randomize them into either Listerine as an intervention or Bioactive as the control, which is a mouthwash that we show there's no effect in the in vitro study. And unfortunately, like the result were very disappointing that like we didn't see any differences like in throat gonorrhea positivity between two arms. So we also used the saliva sample to look at oral microbiome over the 12 weeks time, and And we actually look at how this affect the oral microbiome after mouthwash use. So what we found that there were minimal changes to overall structure of the oral microbiome over 12 weeks, regardless which mouthwash they use. And the study actually suggests regular use of antiseptic mouthwash is unlikely to cause major long-term disruption to balance of oral microbiome. So we also did this omega-2 trial, which tests daily mouthwash for 14 days, could treat through gonorrhea instead of using standard antibiotics. However, the trial actually stopped early because we only found 20% of patients were cured using mouthwash compared to 100% using standard antibiotics. So to conclude, saliva can be saliva can detect several sexually transmitted infections, including gonorrhea, chlamydia, mpox, and syphilis. It is always often used in sexual activities and also play a major role in SDI transmission. However, saliva is not an approved specimen for SDI diagnosis in Australia currently, but it actually have the capacity to grow because it's a very easy sample to collect for convenience and also a very non-invasive sampling. And lastly, I would like to thank all my collaborators and all the team members to bring all this work together. Thank you.
Thank you for the presentation, Dr. Chow. Very, very informative, and certainly appreciate you joining us at such an early hour and being able to deliver such a lovely conversation. I am very pleased that we're now going to shift over into the question and answer portion of our session. And so this is going to be for all of our panelists. The first question that came in is actually going to be for Dr. Vigerust. And the question was, is detection of cationic analytes in saliva a problem due to electrostatic interactions with mucins?
That one's for me.
Yes, that one came through during your presentation.
That's a great question. I don't know if I can answer that.
Okay. Well, we can.
Cationic analytes. I don't know. I'll be honest.
Seems like a good research question to consider then. Maybe
Yeah,
I'll connect you with the person who submitted this one for a sidebar conversation about what might make sense going forward.
Yeah, we haven't had to deal with that as yet. So
Brilliant. I see Aaron's raising your hand. I'm going to go ahead and unmute you, Aaron, so in case you want to expand. Aaron's going to be joining us as a panelist on a upcoming session.
Hello, can you hear me?
Yes.
Oh, good. I thought it was a very interesting presentation you gave. The things that I'm concerned about are charge. There are a lot of innate immune response elements released from cells into the saliva. And mucin is negatively charged. There's a lot of sialic acid residues on mucins, and mucin is a huge molecule. So I was wondering, when you are attempting to quantify the levels of any innate immune analytes for the sake of looking at immune responsiveness, innate immune responsiveness, if the mucins themselves could present a problem because you might have to detach or remove the mucin in order to quantify those targets you're looking for.
right.
That's where the question comes from.
Well, the stabilization solution that we have developed as part of the company that I'm CSO does a fairly good job of disrupting all of that, mucinogenic or mucin component. So we end up having a very homogeneous solution. We don't have very much in the way of this really thick viscous sample by the time it gets to the laboratory. I've not considered that question about whether or not the mucin is interfering with our ability to detect, some of these pro-inflammatory markers. We've had very good success so far across all of those different platforms. But I didn't consider, could that quantitative value have been higher if we had accounted for that?
Something to consider for sure. And I think that's a great example of the kind of cross collaborations and the just general conversations that we really appreciate that come out of this conference. And so hopefully we can get you guys to connect later on to maybe continue that.
Sure. I appreciate the question. Thank you.
Wonderful. Thank you. The next question that came through is for Dr. Sabino-Silva. The question is, can you detect HP in saliva of people with GERD?
Thank you for your question. We are working now in a project to collect saliva in the GERD patients, but we don't have results today, but we are working in this area.
Thank you. The next question that came through is for Dr. Chow. And the question that came through is, did you consider or test with any comparator tests other than the Aptima 2 combo assay for gonorrhea? If so, what were the results? Were they comparable?
Yes, thanks for the question. So Aptima combo was used because it's actually our diagnostic lab actually is using the diagnostic test, but with the larger multi-site trial, different clinic actually use different platform to test. So they also use other platform like Roche. So we also collect the data as well. So we actually retest the sample using Aptima and also compare to other assay they use. So it's actually very concordance with different assay.
Thank you for that. There's some more bigger picture questions that were identified while you all were presenting. And one of them was looking for feedback, and this is open to the entire panel, of what kind of opportunities do you see for saliva, particularly in low resource settings? So Dr. Sabino-Silva, maybe you can kick us off since that was a item that was really featured in your talk today.
It's a very good question. I really believe that we think in this area because the several problems in systemic or oral disease occur in low-income countries, and we, as soon as possible, to think in this area to improve it. We are working with some biophotonic device that we don't use any reagent, and in some cases it can improve it. We also are working with some samples provided by the Amazonia in Brazil, and there are a large community in that area that don't have access to move to the health centers. And in this case, when it's possible, we need believe in sustainable and also cheap diagnostics.
Thank you. Thank you for that. That's a good segue and a good teaser for some of the presentations that are going to be coming up tomorrow, looking at how we're able to connect these kinds of diagnostics with lower resource areas. Dr. Vigerust or Dr. Chow, would either of you like to add in? Oh, Dr. Vigerust, you're on mute.
Sorry about that. That's been one of the things we've been considering as well. And part of what I was mentioning during my portion was the ability to stabilize your sample. So if you're someplace where you don't have a point of care device, you don't have access to something, I mean, almost immediately to do your sampling or to do your testing, being able to transport that sample in a stable fashion where you don't degrade the sample at all, whether it's a proteomic sample or genetic sample or whatever. We've spent a lot of time trying to think about how can we develop a solution that allows for no refrigeration, can be collected anywhere, can be sent, in the blazing heat of summer. We did have a project a couple of years ago in Africa that was intended to allow us to be able to test that out. Can we get the samples collected someplace that just doesn't have access to a lot of equipment or doesn't have access to some of the diagnostic platforms, and get that sample reliably to someplace where they can analyze it? But I mean, ideally, if you could do it on the spot, if you could do it in the field and get an immediate result, that'd be ideal.
Thank you for that. That's something certainly our team is working on with the mobile lab in a van that we're deploying into various areas and communities, and being able to have saliva as that sample type that can withstand heats and cold and doesn't require specific transport is huge. Dr. Chow, is there anything you'd like to add to this idea of sustainability in low resource settings?
Not much, but yeah, I just want to echo. I think it's very important, particularly like in country is in a very large country like with regional and remote area, and people may not be able to access like healthcare services, and they may not be able to like easy to get tested. So when they can post very easy sample like saliva sample, that will be really good like for any diagnostic.
Absolutely. And we have a question that just came through that aligns with this. So I'm going to go ahead and tag over to it. One of the questions that came through is, how stable is the saliva sample after collection? Is there a time range within which testing used to be performed or needs to be performed after collection? And so maybe you each can speak to that for the particular areas that you work on, recognizing that there's probably going to be some variability depending on what you're looking for.
The stability in the collection device that we currently use is we have it validated, at least for the US, we have it validated out to 28 days. We'd like to get the sample within 28 days. It doesn't matter what the temperature is. We've done temperature excursion in Arizona, in July in a brown UPS box, and we've tried to just fry it, and it's worked out just fine. The stability of the sample beyond that, we've got stability out to 2 or 3 years, and the sample is still viable in the collection media that we've developed. And I know that there's a number of companies that have done this, right? So there's others out there that have stabilization solutions that work really well. In our particular, situation, we like to get the sample within that first 30 days. But it's actually, technically, we've done aging studies to show that the sample is still viable after 2 years at room temperature, right? So if you can at least keep it out of the sun for an extended period of time, I think you have plenty of time to get it to the analysis.
Our team's done some similar studies where we've done the heat and the thaw and the freezing and all of the things in between, though. Having been someone who lived in Arizona for many years, I can attest that 120 degrees sun in a box would certainly put it through quite the test.
Puts it through a challenge, yeah.
Absolutely. Dr. Sabino-Silva or Dr. Chow, anything to add or thoughts on saliva as a stable sample type?
Yes, I'm in accordance with David told us. We have worked in a project with a heel prick test because we are trying to have one specific polymer to get one saliva dry biobank, because in that case we can have the presence of the peptides unchanged, the 3D conformation, and maybe it can improve the connection of antibodies and antigens to have a better detection. But also, as you told us, it's very different for different type of platform. We will have a different condition to maintain saliva. But I believe that the presentation of Professor David are very important in this area, because he told us a new project in this area.
Dr. Chow, how does the stability of saliva as a sample type play into the work that you do?
It's a very good question, and also I'm not a lab person, so we really rely on like what our lab actually told us to do. But it's very aligned with what David said. Like they recommend like within 30 days of the sample at room temperature. So we highly encourage the patient, once they collect the saliva, they actually put it in the post, and then we usually get the post like within a week, and then we process the sample. So mostly we'll probably like done it within like 30 days. So I don't think we have any samples like could be on 30 days. So which is also kind of a good way that like we align with what the lab said, but very good to hear that like you can probably be stable for up to 2 years.
Thank you for that. One of the other questions that came through was what you are particularly excited about when it comes to advances in the field of saliva diagnostics. Each of you shared a number of different projects, but there was a curiosity of if you each could pick the one that you think has the greatest potential or that you're most excited to see move through those regulatory processes. David, do you want to take this one? You're off mute.
What am I most excited about? Where we're really trying hard to, to work with functional medicine, to work with some of those that are trying to use saliva as a way of just better prevention, better early diagnostics, early detection of things. And we don't really have, in the US at least, we don't really have a very robust preventative medicine approach. We're very reactionary. And I think part of it is because people don't want to have to come into the lab to get stuck. They don't want to, they don't want to do that. They don't want to come sit in the patient service center and wait for 2 hours to get, a 5-minute blood draw. So if we're able to develop some of these things where they're stable and they can be sent out to a patient, ultimately, if we can get to the place where the results can be detected on a phone or on, something where they can get almost the immediate result and then feed that back into their provider. That's the kind of thing we're really excited about working on is just trying to give people access and trying to get them access early enough that they don't get to the place where there's a chronic condition that's debilitating them, right? On average, most of our population probably has, between 3 and 7 chronic conditions. That's a very big disruptor to quality of life. So I'm really excited about trying to do things that are going to give people visibility early.
Absolutely. Breaking down those barriers so that way you can give earlier access to diagnostics. And we got a well said. There you go. There's certainly some appreciation for that. Robinson, I see you take yourself off mute. Was there anything you'd like to add?
Yes, it's an interesting question. In the case of photonic biosensor, is probably we will need more time because there are groups in the Europe that are working in the photonic biosensor for to detect brain cancer using blood. And I believe that when this start up together with the Strathclyde University approved this system in the Europe and the FDA, it's more easy for other tests using saliva approve using the same technology. In our cases, I believe that when we have one new molecule applied to lateral flow biosensor is more easy to access the market in Brazil because the Anvisa, that is like a FDA in the US, is this agency is more easy to approve one test that are currently approved for other disease. And we have several tests in Brazil that we can use saliva, but we are working to have our proper biomolecules provided by saliva, because in some cases these tests can use one big antibody, and we are working to use smaller peptides to change these tests.
Thank you. Dr. Chow, anything to add?
Yeah, I really want to see more diagnostic like using saliva in sexually transmitted infection. I think particularly we have all these fantastic net assay, but most of these companies actually with their package insert, they actually claim like you can't actually use saliva. They're not approved it. So which actually create lots of like roadblock for us like for diagnostic, and we can only use it for research, and we can't really provide the diagnosis using saliva sample. But there has been like very good self-test kit like using saliva for HIV, and then it will be really good like to move on like to do other sexually transmitted infection.
Thank you. Thank you. One of the questions that came through while we were just on that thread is, do we have an estimate cost of using saliva versus blood sample? And recognizing some of you might have a different standard of care or standard sample type, would you mind speaking to how things compare between saliva and whatever that standard of care diagnostic sample type is?
In the experience that we've had so far, saliva is actually a bit cheaper. It's a little less expensive because you don't have the vacutainer, you don't have the needle, you don't have the phlebotomist, you don't have, all of those things to collect the sample. You just have basically the collection device, and that's all. And then if you don't have to worry about, shipping conditions, it be on blue ice or refrigerator or frozen, then, the shipping costs are reduced as well. So overall, what we found is it's a little less expensive for the things that we're doing, to do saliva over blood.
Yeah, and also I think in Australia about the biosecurity, sometimes blood sample can be very difficult, like to be transported. You probably need to declare quite a lot of things, and I assume it probably also happen in some other countries as well. So saliva kind of like is an easier way. Again, it's also cheaper when coming to transport. Even though for the self-test kit, like we have patient actually find that like the fingerprint is actually sometimes find it very hard for them like to squeeze the blood from the fingers. So yeah.
Yeah, our solution renders it non-infectious, so we don't have to worry about declaring an infectious agent. So that helps too, right? If you have a buffer that can neutralize the potential infectious nature of the pathogen, then you don't have all those declarations to worry about.
Right.
Yes, I am in accordance with the other response, and I just emphasize that we don't need, in the case of saliva, have a trained professionals to get the saliva. We have a personal collection, and this is very important to reduce the price of the collection.
Absolutely. That collection piece all the way through processing definitely impacts the overall cost and cost effectiveness of saliva as a sample type for an alternative. We've got time for one more question that came through before we're going to switch over into going through a different vein, and that's thank you all for your great work, first of all. Is there a practical reason why there are no studies yet for detection of human herpes virus types 1 through 8 or HPV types linked to oropharyngeal cancers?
Using saliva?
Mm-hmm.
Our lab is currently doing that. We're using HSV1, HSV2, CMV, EBV, and 22 different serotypes of HPV using saliva.
I have a prediction that you're going to get an email from this person who submitted this question quite soon.
And we're also detecting monkeypox. We're detecting, so there's the capabilities there.
Amazing. Thank you all so much for answering these questions. Really appreciate it. So again, before we close out, I'm going to tag things over to Yasmin, where she's going to share the video from our Director of Science.
Thank you, Brittany. So I'm going to share the message from Alex, our Director of Science.
Hello, everyone, and welcome. I'm Alexandra Kitz, Director of Science at Saliva Direct, and it's my pleasure to kick off our 4th annual conference with this opening session, Saliva as a Diagnostic Tool for Advancing Accessible Testing. Over the next couple of days, we'll explore the many ways saliva is being used as a powerful and versatile diagnostic sample type. In this session, I'll give a brief overview of why saliva is such a compelling option for testing, why it matters for accessibility, and what we at Saliva Direct have been working on recently, as well as where we're headed next. To kick us off, I would like to go over a slide with general problem statements in terms of clinical diagnostic testing. One of them being that high-quality diagnostic testing can still be a high barrier for test seekers due to income, geographical disparities, age groups, and disabilities. Many diagnostic tests use invasive sampling techniques, for example, blood draws or nasopharyngeal swabs, and these invasive sampling procedures often heighten the risk of exposure for healthcare professionals. Additionally, many diagnostic tests are unnecessarily expensive and are often linked to an inflexibility in terms of the laboratory equipment that can be used to run those diagnostic assays on. In all of this, saliva has been emerging as an innovative and patient-friendly alternative with the possibility to overcome these barriers and pitfalls. To give a brief overview of what saliva is, in its molecular makeup, it's a complex biological fluid naturally accumulating in the oral cavity. It mostly consists of water, up to 99%, with key electrolytes like sodium, potassium, calcium, and so on. Saliva contains a lot of proteins and enzymes that are involved in digestion or antimicrobial defense, as well as additional antibody cells, again involved in oral defense. And saliva also contains its own oral microbiome with a variety of naturally occurring bacteria and fungi. Why are we interested in saliva? First of all, the collection process is simple, it's non-invasive and flexible, which makes it a lot more convenient for patients and allows for more frequent retesting. Specifically for viral respiratory infections, there's no RNA or DNA extraction needed, which makes the overall process extremely simple while it retains a high sensitivity. It leads to very fast turnaround times in terms of results, which is ideal for a pandemic response. And it consists of a cost-effective collection and processing protocol. In the context of SARS-CoV-2 detection, we at Saliva Direct were able to show that both DNA and RNA for respiratory infections are extremely stable in saliva and remain stable for an extended period of time, which open up a lot of opportunities for decentralized testing and at-home collections. On the right-hand side, you can see graphs showing that we exposed saliva to a variety of storage conditions. In panel A, we compared frozen and thaw cycle, room temperature for 5 days, and temperature exposure of 30 degrees for 3 days. And you can see that the CT value, in this case for the N1 gene of SARS-CoV-2, remains stable across all those conditions. And the same is true if we expose saliva to storage condition for multiple days at room temperature, with the N1 expression level also mostly remaining stable over time. This makes saliva a very versatile sample type that carries a lot of biomarkers for a variety of infections and diseases. And as I mentioned, we are focused on respiratory diseases like COVID, flu, RSV, and strep A. But we'll learn over the next couple of days there are other applications like other infectious diseases, for example, oral SDI detection. There are applications for cancer detection, both for oral and non-oral cancer types. Saliva can be used to diagnose and monitor concussions and TBI, additional neurological diseases and mental health status, as well as monitoring women's health. This slide depicts a survey that we and others conducted. It contains survey data from over 2,000 participants from 125 countries across the world. And the aim was to see what kind of sampling method people would prefer for SARS-CoV-2 testing. And I'm not going to go into too much of detail here, but as you can see in teal, we have saliva, and overall the percentage of respondents that prefer saliva or an oral swab over nasal pharyngeal swab or generally nasal swab has been strikingly, which means saliva is a broadly very wide accepted sample type and would be preferred by a lot of patients for testing options. Coming back to what we work on at Saliva Direct, this slide gives you a brief overview of our Saliva Direct assay protocol. Our Saliva Direct assay protocol is a COVID RT-qPCR example, and it has very fast turnaround times, again, due to the fact that we don't need an RNA or DNA extraction step to detect the virus. Because of that, the costs of this assay protocol are very low and come down to $3 to $5 per sample. It's a very easy setup with a single workflow, which can be deployed to a large laboratory network in a short amount of time. And these simple workflows can also aid in the creation of standardized protocols. And on the right-hand side, it depicts how the workflow, the process functions at a very high level. So you can see we have a saliva sample that contains all the various ingredients that we discussed prior. And this saliva sample is incubated with or without proteinase K. The proteinase K in this turn digests the viral proteins and releases the viral RNA into the sample, which can then be detected by RT-qPCR. What Saliva Direct did with that technology is that we created a designated lab network throughout the pandemic. It consists of over 200 CLIA laboratories over 42 states throughout the US. And throughout the course of the pandemic, these labs performed 6.5 million tests. This is a very scalable model that allows labs to activate testing when there's a demand and also to hibernate when the demand is low. And Saliva Direct manages the test quality data and oversight with the regulatory agencies. This model now, post-pandemic, can be used to provide a market for the deployment of other LDTs in a very controlled environment. The next 3 slides I'm going to present are going to show you some other avenues Saliva Direct explored in increasing accessibility for the Saliva Direct COVID test protocol. And one of them was the collection kit distribution to vending machines. The advantage of this project was that vending machines provide people with 24/7 access to the test kits. It anonymizes the testing process and can reduce the stigma. And these vending machines can be deployed widely in a variety of community locations with very easy access. It's a potential solution for reaching underserved or geographically isolated population, and it offers a potential for use in a workplace health program or educational institutions. A second project that we piloted was the use of mobile laboratories, or as we call them, a lab in a van approach. These vans, as depicted on the bottom right picture here, are equipped with compact molecular testing system, a very small footprint RT-qPCR system that allows for testing on site. The vans are bundled with CLIA laboratories, so they have an active CLIA license for high complexity testing and can be staffed by 2 staff members, for example, a lab tech and a community engagement lead. And what we did with these vans is we deployed them to areas with low access to diagnostic testing, for example, at community events or home care settings, and provided access to COVID-19 testing to underserved communities. The last project I would like to highlight is coming back to the standardized protocol deployment. What we've been working on here is with a pilot project in Malawi, the laboratory capacity building in low-income settings. So Saliva Direct provided on-the-ground training in one of our novel protocols targeting SARS-CoV-2, RSV, and influenza A/B. And we thus want to heighten or increase the international implementation of standardized protocols. So in this pilot protocol project, the team in Malawi tests saliva and paired MP swabs. And what they can show on the bottom right here is that there is a substantial agreement between saliva and MP swabs using our Saliva Direct protocols. Interestingly, also in this collection, or in this season that's depicted here between January 2024 and September 2024, they were also able to detect flu in a subset of additional samples with the saliva testing versus the MP swab testing. And with this, I'm already coming to the conclusion of my talk with future projects that Saliva Direct is involved in and interested in. Post-pandemic, we are now looking into LDT development and controlled assay oversight for other infectious disease targets, utilizing our laboratory network. So we're interested in developing and deploying LDTs for respiratory multiplex detection using RT-qPCR in a variety of multiple configurations for different targets. We're involved with SDI screening projects in high-risk populations. And we would like to combine this LDT development with our laboratory network and the mobile laboratory approach to increase the testing accessibility and capacity building in the US, as well as be involved with more capacity building in low and middle income countries. And with this, I thank you for your attention, and I hope you enjoy the conference. Thank you.